Please mute your mic also, ma'am. Echo sound will come.
I didn't say that we are going live.
We are live now. Kindly mute your mic. Yes, Dr. Urvashi, you can start.
Okay. Hello, everyone, and a very good afternoon. Hope you guys have had a nice lunch and are ready for an exciting session today. I am Dr. Urvashi Tawar, your host and host for the clinical series organized by Dental Reach. We are basically a digital dental magazine acting as a podium and online community for dentists where we can share ideas, articles, blogs, and many more. And today I would like to introduce you all to the mentor for this clinical series called The Right Bite: Harmony Between Aesthetics and Function. Now, this will be a series of 6 lectures starting today with Smile Rehab Strategies Part 1, and we'll continue on to Smile Rehab Strategies Part 2, followed by deprogrammers using what we have, then selective FMR, is that even possible, complex occlusion, and customizing occlusion. So all these things are interconnected, and I would really recommend you watching all the series in order. And these lectures will be taken by none other than Dr. Deepa Ravichandran. Dr. Deepa Ravichandran is a prosthodontist in Navi Mumbai, where she runs a successful private practice under the helm of Dental Park. She has won awards at both state and national level in her master's program for both paper as well as poster presentations. She has many publications in index journals, Guidant, Famdent, Jida, to name a few. Presently, she is the brand ambassador and moderator of Dental Reach, the recipient of GOMA Awards for 2021 and 2022, the recipient for Doctor's Choice Awards National and City Winner 2021, mentor for Pulp Tent Activa Pronto Challenge, the silver winner in the Dental Divas Endo Resto Contest 2021. She's also been a contributing author in How to Conquer Dental School, a one-of-a-kind novel giving young undergraduates a unique perspective in navigating the maze that is dental school. Her forte lies in full mouth rehabilitations, smile designing, and restoring cases of complex occlusion conservatively. She has received acknowledgement for the same from peers and patients alike. Over to you, Dr. Deepa Ravichandran.
Thank you so much, Dr. Urvashi. That was a very, very beautiful introduction. So without much ado, I will be sharing my screen so that we are able to move on with our topic for today. Is my screen visible?
Yes, ma'am. Can you turn on your video also?
Yeah, I did not do it earlier because I feared the bandwidth, but
Okay, fine.
yes. So should I switch it back off? I thought of turning it back on at the end. Is that okay?
That's fine, ma'am.
Okay. So as Dr. Urvashi mentioned, our topic for today is smile rehabilitation, part 1. What makes or breaks the smile curve? Now, we all get a lot of cases of smile designing in our clinic. So why am I titling my presentation as smile rehabilitation? Why have I not called it a smile makeover or a smile design? The reason is because we need to understand the importance of functional occlusion and the role that it plays even in cases of anterior aesthetics, which sometimes is often neglected. So if we have a case where we are making only very subtle changes to the shape of the tooth or very subtle changes to the length of the tooth, that would be a smile design. But if we are to change the functional occlusion, and by that I mean the anterior guidance or the overjet or the overbite, in order to incorporate aesthetics with function, in that case, it would become a smile rehabilitation. So these kind of cases are a little tougher. They are not your usual smile design cases. They are not your usual smile makeover cases. And the stakes in such cases are a little high because the case itself is such that if the functional occlusion is not corrected, the restoration is not going to last. Whether it is a crown, whether it is a veneer, either composite or porcelain, it's definitely going to chip, it's going to break, and this causes a lot of issues in our practice, especially in front of the patient. The patient tends to lose faith in the practitioner. There is the financial involvement at the back end too, because if it's a case of veneers, many labs do not give a warranty for veneers. So if there is a chip or a breakage, it's on the practitioner. Even though labs give a warranty for crown, it isn't unlimited. So they may replace it once, but they do not replace it the second, third, and the fourth time, in which case, again, it becomes the responsibility of the practitioner. So how do we avoid these type of challenges chairside? We avoid it by understanding the case in totality. What are the patient's expectations? And normally the patient's expectations are usually aesthetic. But we as a practitioner need to analyze the case and understand what are the functional prerequisites that the case has to have before the aesthetic expectations of the patient are met successfully without any chip or breakage of the prosthesis. So this is a case-based series. The entire series, I would be discussing my cases in great detail. So I would, in most of my presentations, I would be picking up one particular case and discussing that entire case from start to finish in detail. And if there are any questions, please feel free to the chat box. And Dr. Urvashi will just interrupt me where appropriate and ask the question, because it is easier to answer the question at that time and place when I'm on the correct slide rather than to answer it much later at the end when the presentation is over and the slide is no longer in front of us. So I had a very young lady. She was about 20 or 21. And she came to my operatory. And she had a lot of complaints about her anterior front teeth, which is basically these two teeth here. And she was not in the phase where she was looking forward to having a productive session with the dentist, or a session where she would trust the dentist and the dentist would advise her what needs to be done and she would just go ahead and do it and that would be the end of it. No, she had a bad experience in the past because she had undergone orthodontic treatment only in her maxillary arch selectively between 2012 and 2013. And as the case progresses, you would understand why she had lost faith in dentists in general, because there were a lot of issues with the so-called orthodontic treatment. Now, her central incisors are actually overcorrected with respect to her lateral incisors. Now, the proclination of the 2-2 is far more than the proclination of 1-2. There is even a mismatch in the proclination between 1-1 and 2-1, in the sense that when you compare the proclinations between 2-1 and 2-2, the discrepancy here is far more as compared to the discrepancy between 1-1 and 1-2. So in short, we have retruded central incisors and we have proclined lateral incisors. And we have caries, class 3 decay between her two central incisors, and we see a diastema. Now, according to the patient's history, the diastema was not present at the conclusion of the orthodontic treatment. The diastema had in fact been created when this decay started. And she has a class 2 freedom, but after going into great detail with her orthodontic history and the appearance of this diastema, it was determined that the class 2 freedom was not responsible for creation of this diastema. And so we decided to just leave it alone and not go in for phenectomy and all of that. And the patient too agreed and she declined it and she was not interested. So even this diastema, it is not exactly because of a lack of maintenance of oral hygiene or a lack of brushing per se. This particular diastema and her caries have got a lot to do with her functional occlusion, and we should understand that as we go ahead. So whenever we get a case like this, or I get a case like this, the first thing that I do is I sit and I note down all the corrections that are needed. And when I say all the corrections needed, I do not mean all the corrections in the entire arch, because let's face it, we have two types of treatment plans. One is the ideal treatment plan and the other is a compromised treatment plan. So a patient may require multiple corrections in multiple quadrants all over in the mouth, ranging from restos to like arch alignment and occlusion, posterior occlusion, etc. But that may not exactly be what the patient is looking for. So what I do is whatever corrections I note down at first are to do with the patient's chief complaint. Because if you tell the patient too much, too soon, in too short a period of time, they tend to run away. So the corrections with respect to her chief complaint, which was this area, the 1-1 and the 2-1, On a very conservative scale, the corrections that we needed were class 3 restorations, correction of the midline diastema, correction of the proclination of the central incisors versus these two lateral incisors, as well as coinciding the midline between the upper central incisors and the lower central incisors, because it's very obvious that right now there is no coincidence. And also achieving broad stress distribution in the position of mutually protected occlusion. Now, what is mutually protected occlusion? Mutually protected occlusion is a component of anterior functional occlusion or anterior guidance, which is very responsible for the success or the failure of any type of anterior prosthesis or anterior restorations. So what does this mutually protective occlusion mean? It's very simple. What it means is the protection between the anteriors and posteriors is mutual. That is, in position of maximum intercuspation, such as in this image, okay, it is the posteriors which are in contact, not the anteriors. And therefore, the posteriors protect your anteriors. But when the patient protrudes the lower jaw forward and brings the anterior teeth in an edge-to-edge bite, the posteriors are supposed to disocclude so that it is only the anterior teeth touching while the posterior teeth are not in contact. So basically, we have contact only between one out of the two. It's either the anterior or the posterior, never both simultaneously. And that is why it is called as mutually protective occlusion. The concept of broad stress distribution, I will explain it in detail as we go further, because it would not make much sense to go into too much detail right now. So just hold on to that one thought. But the reason I mentioned it here is because it's a very important concept when we are planning cases of smile rehabs. So it's something we have to take into account right from the get-go. And sorry, there was an issue. Okay. So now what did the patient want? This is a very, very important question, because we may want to do a lot of things for the patient. We may want to do a lot of corrections, but the patient may not want that. And as I said earlier, there are two kinds of treatment plans. One is the ideal treatment plan and the other is the compromised treatment plan. So many times what we want is the ideal treatment plan, and what the patient wants is a compromised treatment plan. And we have to find a way to get the two to align and to find a balance between the two, because ultimately it is the patient's wish in private practice. Especially, we cannot force somebody to do something that they do not want to do. So in this case too, the patient had a choice. She could undergo orthodontic treatment once again and get it done correctly this time with both her maxilla and her mandible, and get the alignment and the proclination and everything correct. Or we could correct it prosthetically. Now, the patient was not interested in undergoing ortho one more time. For her, that ship had sailed, because she had had a bad experience and she did not want to go back to wearing braces, and she was not a case for Invisalign or any type of aligners for that matter. Why? Oh, there are photographs ahead, and when you see her bite, you would understand why. So for many patients, this happens. For whatever may be the reason, they are a case of ortho failure. And once they have had failure in ortho treatment, which they have undergone in the past, they are not very keen on undergoing it one more time. And hence, we went in for the prosthetic option. So now when we come to the prosthetic option, there are again parameters that we have to explore. So do we do crowns or do we do veneers? And we need to first answer this question, and it's very, very important, because the outcome of success or failure depends on this decision. If you choose to do veneers in a case where you need to change the anterior guidance, and sometimes that can only be done with crowns, the veneers are going to chip, they are going to fail, and there is going to be a breakage, and there is obviously going to be a prosthodontic failure. And it does not matter whether you do composite veneers or whether you do porcelain veneers. Veneers as a treatment line are part of minimally invasive dentistry, yes, and they're highly successful, no doubt about it, but they require very careful and selective cases to which they can be applied. They cannot be applied to any and all cases of anterior aesthetic corrections. So if the anterior guidance is correct, yes, if veneers, if done, would be highly successful. But if the anterior guidance is wrong, whether it's a composite veneer or whether it's a porcelain veneer, it is going to chip and it is going to fracture. So we need to visualize the corrective functional occlusion that we want to give the patient in the future. And what do I mean by in the future? I mean at termination of the smile rehab. And whenever we want to visualize the correct functional occlusion, we need to understand what type of anterior guidance the patient has. Does the patient have a steep anterior guidance? Does the patient have a shallow anterior guidance? And what is the difference between these two and how does it impact our anterior aesthetic treatment? This part I will discuss in detail in the next slide. But for now, Dr. Urvashi, could we have the poll on minimally invasive dentistry first?
Yes, I'm just putting the poll.
Yeah, so it's just a yes or no answer. So, just click the first thing that comes to your mind. Please do not take up too much time on it. Now, meanwhile, this particular image that you see on the screen over here, this is a chair-side mock-up that I had done for the patients with composite, just to show the patient what it's going to look like if her diastema were closed and her caries were restored. I had not restored the caries in this mock-up. I had just done a very rough chair-side mock-up. I didn't put too much effort in it because I knew that composites are not going to be successful in this case. Now, why do I say that? It's very simple. When you have the central incisors retruded, like in this case, because I had made it very clear to the patient that if she wanted only composites and she was not willing to let me correct her anterior guidance, because I cannot correct it with composites, I cannot correct the mismatch in the proclination. I can only close her diastema and I can only correct her class 3 decay. That's it. The thing is, her central incisors are retruded, her lateral incisors are proclined. So in effect, her arch form is compromised. She does not have the natural U-shaped curve that is needed. She would end up having something like her laterals going like this, then her centrals coming like this, and then her laterals going like this. So something which is a little squarish in the anterior region, around the region of the central incisors. So when the patient brings her upper and her lower anterior teeth in an edge-to-edge position, since the upper central incisors are retruded, they are the teeth which are going to come first in contact with the lower incisors, always. Now, this is why I spoke about broad stress distribution earlier in the earlier slide. Now, according to the concept of mutually protective occlusion, there should be equal and bilateral load distribution between the upper as well as the lower 4 incisors, which means we are talking about the upper centrals as well as the upper laterals, and the lower centrals and the lower laterals. So we are talking about a 4-point contact between the upper and the lower anterior teeth, ideally, and if not 4, at least 3. But in this case, since her central incisors are retruded, they are going to be the first teeth that come in contact. So it becomes a 2-point contact and not a 4-point contact. And therefore, there is no broad stress distribution here. All the stress is borne only by the 2 central incisors, and most of the load would come right here at the junction between the 2 central incisors, which is exactly where the buildup is. And that's why there's going to be a repeated fracture in this area over and over and over again. And if that happens, and you see that there is a pattern to the fracture where it's taking place again and again in exactly the same area, it means that there is an issue with the functional occlusion, not with the etching and the bonding protocol of composites. Dr. Urvashi, do we have the poll results?
I posted them. They were 100% for no.
No, as in no minimally invasive dentistry in this case.
That it means like no, minimally invasive does not just mean veneers.
Okay, great. I'm really, really glad we got this answer. So yes, that's the whole point of this presentation. Minimally invasive dentistry does not just mean veneers. No, it doesn't. I'm going to go back to my previous slide for just a second. Not this, the one before that. Yeah. So when I said we need to make a list of all the corrections that we need with respect to the chief complaint of the patient. So what is minimally invasive dentistry then? If it doesn't mean just veneers, if it doesn't mean just PLVs or composite veneers, what does it mean? Minimally invasive dentistry is the correct way. The correct way to address minimally invasive dentistry would be to make a list of all the treatment that a patient would need, and then achieving the maximum that we can with the minimum that we do for the patient. In effect, what I'm trying to say is, if I can achieve all of this in, say, just 2 crowns without touching anything else in the mouth, then yes, it is minimally invasive dentistry, because you're achieving so much with so less. So it's not that crowns are always radical and veneers are always conservative. It's not like that. It all depends on the functional occlusion of the case. And rather than having veneers that are going to constantly chip and constantly break and constantly debond and probably chip some of the enamel of it, and enamel of the tooth also off, it's better to analyze the case correctly. And if the case needs crowns, it needs crowns. There is really nothing wrong with it, especially if the patient has chosen to undergo the prosthetic option and not the orthodontic option. So now the patient, being a typical Indian patient, did not want to do the correct treatment, which was crowns, whereby I correct everything that I had mentioned in the slide before. She just wanted a quick fix solution because, as I said, it didn't have much to do with finances. In her case, it had a lot to do with not having faith in the dentist. That is, having the feeling that I'm not going to get the correct treatment for the money spent, or I'm not going to get my value for the money spent, that sort of a thing. So these kind of patients are very, very difficult to handle, and you need to really be very careful. So I didn't push her. She wanted a mock-up. I gave her the mock-up. She said, let me try it out with composites. But this is where I made my exit very clear to the patient. I already told her in advance that there is going to be chips, there are going to be breakages, and it's because your bite needs crowns to correct it. Ideally, it should have been corrected in the orthodontic treatment, but for whatever may be the reason, it wasn't. So now that we are fixing it prosthetically, we got to do it right this time, because let's face it, we can't keep doing it again and again. So if I have to fix it correctly once and for all so that it's going to last you a lifetime, then I cannot do it for you with composites. I cannot give you a Sasta Sundar Tikau solution over here. You have to do it with crowns. And she wasn't very convinced. And she said, no, let's just try. I want to see. I said, okay, no, it's not an issue. We'll go ahead. I'll give you composites. But be warned, it's going to break. So that way the patient cannot blame me later when the chips and the breakages happen, and they're inevitable. And I want the patient to not incise. And I think I did this in 2018, but when she came back to me for the final phase of the treatment in 19, I think she had already broken it 3 to 4 times. And the fracture occurred exactly over here. And by then the patient had understood that despite her best efforts and despite her trying not to incise, she still ended up doing it. Her exact words to me were, I'm really sorry, I try my best, but it just happens. And that was exactly my point. It's not the patient's fault. It's just happening because our anterior guidance is all wrong. So if we want to protect our prosthesis, we have to take care that it doesn't just happen. And that can only be done when you change the anterior guidance of the patient. So once we have the repeated chips and the fracture, she herself became open for the alternative treatment of crowns. And I didn't document the entire pattern of the chips and of the chips and the breakages and maybe redoing it, because it wasn't something that was going to last. So I didn't see the point of documenting it back then. But in hindsight now, I feel maybe I should have, because it would have given us a beautiful timeline of what works and what doesn't, and if it works, for how long it works and in what conditions. So, we all learn from our mistakes, and this is something I have definitely learned from, so that in my next case, I will document something, even if I know that it's not going to work. So now I'm going to explain what is anterior guidance and what is shallow versus deep. Now, anterior guidance is nothing but the angulation which is formed between the incisal edges of the lower anteriors and the convexity of the palatal surface of the upper anteriors. So you can see that there are two different angulations over here. You have angulation A and you have angulation B. So angulation B is acute, angulation A is obtuse. Now this means that the angulation in A is far more than the angulation in B. So angulation A is considered to be steep and angulation B is considered to be shallow. And that's fine. But how does this really affect our prosthesis? And how does it really affect the success and the failure of our prosthesis? So let's consider two speed breakers over here. We have a car which is moving on the road and we have got two speed breakers. We've got one in yellow and we've got one in black. The one in yellow is your steep anterior guidance because it's got a greater angle. The one in black is your shallow anterior guidance because it's got a lower angle. So when we drive and we approach these speed breakers, we require far more effort to brake up, to apply the brakes, to slow down, to deaccelerate, and to go over the yellow speed breaker, which has got a greater angulation, as compared to the black speed breaker, which has got a lower angulation. It's the same in the mouth. It's exactly the same. When the patient has a greater angulation, the patient requires to exert far greater effort into bringing the upper and the lower anterior teeth into an edge-to-edge position, which they find difficult. And so they don't do it. So patients who have a steep anterior guidance will not be bringing their anterior teeth edge to edge in that unnatural position, straining their neck muscles and trying to incise. They're not going to do it. And this is where the success of the prosthesis lies, and thereby a prosthesis is successful. But if a patient has a shallow anterior guidance, it is very easy for that patient to bring their upper and lower anterior teeth in an edge-to-edge position because this convexity over here is shallow. So it's very easy for the incisal edge of the lower incisor to travel this path and come to this position over here. And therefore, such patients incise with ease. And this is why the prosthesis is going to fracture here, right here at the incisor edge, unless this is converted into this. And this conversion cannot be done with composites or veneers, porcelain veneers, because you need to change this angulation, this convexity over here. And sometimes to change this angulation, the convexity over here, we also need to push the tooth out in the arch to recreate the arch form. Now, another thing that a lot of you might be thinking is, but today we have injection molding and it's not that difficult to alter the palatal surface of the upper anteriors the way it used to be in the past. Prior to injection molding, we could only fix the labial surface and not the palatal surface so much. Yes, I do agree that injection molding has made life a lot simpler. Where composites is concerned, you get a better finish, you get a better polish. It's so much more easier chair side. We save a lot of time. It's more predictable and all of that. But the tenets remain the same. That is, the corrections that are needed for this patient in order to have success, which is correcting the proclination, correcting the arch form, all of that remains the same. So to achieve all of that, you would have to prep the tooth the way you would have to do a crown prep. There is no other way out. And then you may choose to injection mold, in which case we would have 360 degrees of composites. And then we need to understand, are composites going to have the same degree of compressive strength or flexural strength as the ceramic? And the answer is no. And that is the reason why even in full mouth rehabs, whenever full mouth rehabs are done through injection molding and composites, they're always considered as long-term temporaries. They're never considered to be permanent restorations. So that is the reason why that's not going to work in this case. Every time the lower incisor is going to travel over this palatal convexity, even if you've tried to change it through injection molding, the surface will not be able to take the repeated back and forth movement. It's not possible. Somewhere along the line, it's going to chip. It's just a question of when. So injection molding may last a lot longer than just a very simple mock-up done the traditional way, but it's not going to last forever. Are there questions regarding the concept of anterior guidance? Has everybody understood it? If there are any questions, do ask. Okay. So we now come to the resto and the preps. The first thing I did was excavate the caries. You can see that they're quite deep. It's gone pretty deep into dentine, and it's not in enamel anymore. And when we finally decided to do preps for this patient, I tried. There are certain parameters that you need to take into account when you do crown preps, when you've decided to give crowns for these kind of cases. I wanted to be as conservative as possible, so there was no root canal done. Both the preps were vital. As I said earlier, there is a very clear mismatch in the proclination between the lateral incisors and between the central incisors. So we've got to correct that. So as such, since I'm trying to move this tooth out of the arch and I'm trying to get it more forward, that is, I'm trying to increase the proclination. And since I'm trying to increase the proclination, I don't need to prep so much on the labial. I need to prep a little more on the palatal instead. So that's what I had done. And I tried to keep the preps as minimal as possible, because the crowns planned were not PFM. The crowns planned were zirconia, which were layered with lithium disilicate. So zirconia crowns allow a little more minimal preps, and thereby allow me to maintain the vitality of the tooth. The other thing we need to keep in mind is to not damage this interdental papilla. If this interdental papilla is damaged, there is a chance that, you know, on the good side, you may not get recession, but then you may not get an interpapillary fill either once the two crowns are placed, because I was planning to place individual crowns. And on the bad side, you may get a slight bit of recession and a black triangle, which is even worse after you have already placed the crowns for the patient. And the papilla over here has already collapsed, because the diastema had existed for quite a few months, because of which you can very clearly see that the papilla had collapsed. These were the crowns, and the function was correct. And what I mean by function was the anterior guidance of the patient was correct. How do I determine it's correct? There are slides ahead which will show you. But the form, not so much. You can see that they are far too broad, and that the length, there is a mismatch in the length between 2-1 and 1-1. And I'm not very happy with the shape also, because it's very boxy and very squarish. Now we have a choice over here. We can choose to do these corrections chair side, or we can choose to send it back to the lab and we can get them corrected, and then we can re-cement it. For me, I chose to do these corrections chair side. I used a disc, and using a disc, I reduced the length of this central incisor to match this central incisor. I also rounded off the incisal edges. Now, when you have square-shaped teeth, okay, they are going to look a lot bigger, you know, from a layman's perspective. So the sometimes that's a compromise that one needs to make in form for the sake of function, because aesthetics has got no value without the right functional occlusion. The only way teeth can be made smaller is if the length is more than the width. But sometimes in certain cases you need to reduce the length, and this was one of them. I had to reduce the length of the two incisors so that in the position of mutually protective occlusion, that is when the patient gets her upper and her lower anteriors in an edge-to-edge position, I would be able to get all these four incisors to contact bilaterally and simultaneously. If I had longer central incisors, once again, I would be faced with the same pre-op issue of only these two incisors contacting with no contact on the lateral. I wanted to share the load between the laterals and the centrals and not have only the two crowns on the central incisors bearing the brunt of the masticatory stresses. So that's a very big component that you have to have in mind. And that's the reason why the length was shortened. But then again, they look more squarish. So now we need to create an illusion of the tooth being a little small, and we cannot be successful 100%. But yes, it can look a lot better than what we see over here. So I can show you what it looked like finally. So as you can see, this was the final post-op smile. Okay. And there is a difference between here and what we saw earlier. There was a difference. The difference is very subtle. But the difference is, and this is the post-op smile taken 1 week later, by the way. I want to go back to the previous slide for just a minute. You can see here, the interdental papilla seems to be slightly compressed. Yeah. So it was not an issue with the fit. It is because I'm trying to recreate the interdental papilla through the form and function. And initially we may have this appearance, but it settles down later. So after a week, you can see this. There is no sign of compression over here. Now, regarding the form, what were the changes I made? What I did was I reduced the length of the two central incisors, and I also rounded off both the mesial and the distal line angles. And I created a little bit of interdental spacing between the two crowns. And that allowed me to round off the mesial line angles a bit more so that I could give a slight illusion of the tooth not being so squarish or not being so broad. As I said, we cannot be successful 100%. It's not possible because if I were to deepen this any further, it's not going to look good. But yeah, it is better than what it was earlier. So as I said, we need to see what all we can achieve. So if we can achieve a lot of corrections with just two crowns, then yes, it is minimally invasive dentistry for this case and for this patient. So this is a comparison between her pre-op and her post-op smile. Okay, you can see that this is how her interdental papilla was, and this is how it is here. This is 1 week post-op, and this is how her teeth were at presentation. And we must keep in mind that she said that the diastema was created only after the class 3 decay, which means that there was contact earlier. So this was not the original width. The original width was more than this. So in that respect, I can say that I more or less maintained the width, but what I've changed is the length. And what we did was we gave a gradation in the shade. Okay, her lateral, shade analysis is a very important part of anterior aesthetics. Her laterals were in A2, her canines were in A3. So as such, it made sense to give her an A1 in the crowns. And I discussed this with the patient, and she wanted a brighter and a whiter smile. So I could have given her A2 too. It's not that A2 would have been a wrong option. It wouldn't have been. A2 would have, seamlessly blended in with her lateral incisors. But she wanted that impact of her front incisors being corrected, and the attention of everyone going here, and then noticing that she had a lovely smile. And so she said that I want it to be more brighter and whiter. I want the focus to be there when people look at me. So this was a lady who wanted that confidence, who wanted to go from here to here. And so we gave her A1. And that was exactly what she wanted. And that you've achieved what the patient wanted, because in one of my recall appointments with the patient, she actually told me this. She said, I play a game with all the people who see me for the first time. I smile at them and I say, one of my teeth are fake. Can you tell me which one it is? And nobody has ever gotten it right till today, is what she said. So that really makes me feel very happy, because that means I've achieved what I set out to do, which is make it really natural. So nobody is able to make out that these two are crowns. She said nobody has ever gotten it right. And when I tell them that my front two teeth are the ones that are fake, they never believe, because they say it's this, or some of them say I don't know what it is. So that shows you that you are successful in your treatment plan and your outcome. So getting the right interdental papilla between the two was very tough, apart from getting the correct anterior guidance in this case. So I had not documented her functional occlusion at the time of cementation because she was in a hurry and she didn't have the time. But when she came for the recall a couple of months later, that's when I documented it. And you can see that I've achieved a very nice interpapillary fill over here. And that's something I want to point out, because getting a beautiful interpapillary fill between the anterior teeth does not just depend only upon the polish. It doesn't depend only upon the form. There is a lot to do with the functional occlusion. If the functional occlusion is incorrect, it starts to reflect here, because if the functional occlusion is incorrect, it becomes traumatic. Once the occlusion becomes traumatic, it could very well end up with recession. But if you have the right functional occlusion, you end up instead getting an interpapillary fill far deeper than what you had earlier. So that shows that things have progressed in the right direction. So it's not only about aesthetics always. So you can see that the value is correct in the second picture over here. And aesthetics is very subjective, okay? What is beautiful for one may not be beautiful for another. So even when we sit down with a patient and we plan for aesthetics integrated with function, we have to discuss the aesthetics part with the patient. What are the patient's expectations? The function they're not going to understand. That's for us to decide. And as I said, aesthetics is subjective. So the aesthetics of each patient varies. So for her, it was very simple. She said, I want a nice smile. I just want the gap between my teeth to be closed, and I don't want one tooth in the front and one tooth at the back. These were her words. I want all my teeth to be nice and even, the way they would have been had I got my teeth orthodontically corrected. The rest I leave up to you. And I was very glad she left the rest up to me and she didn't dictate too much in the term of shape. Because I honestly could not have given her a better shape than this if I had to get a functional occlusion correct. It was not possible in this case. So that's one of the limitations in this treatment. That is one of the limitations, and we have to acknowledge that. And the patient understood and she accepted that. She was fine with it. So this is the position of a functional occlusion, the lateral view, and you can see her entire posterior occlusion is very, very, very bad, for lack of a better word. You can see that this is tilted. We have the first premolar completely out of the arch, the second premolar inside the arch. It's the same on both sides. And the worst part is she has very less VD posteriorly, and she is a class 2, a very severe class 2. Okay, she's a skeletal class 2. So you can now appreciate a proper arch form over here. And you can now appreciate the correction in the anterior guidance. Because when her incisors were retruded, which they were earlier, we would not have got a correct curve of spleen. So despite me not touching any of her posteriors and only crowning 2 anteriors, I have corrected her curve of spleen as much as was possible in this case, in the limited treatment that I did for. And the other thing we need to understand is that her canines are in occlusion with her premolar. So that's not how it's supposed to be, because the canines are not supposed to occlude with the lower premolars if we are talking about an ideal class 1 occlusion. And that is the reason why I said earlier that in mutually protective occlusion, the anteriors do not touch in the position of maximum intercuspation. That is, when the posteriors are touching, the anteriors are not supposed to touch. But in this case, her canine is in contact with the lower premolar. So, these are the red flags. When you have a case like this, a skeletal class 2, very less VD, the posterior occlusion is gone for a toss, and you have the canine occluding with the lower premolar, it means that the mutually protective occlusion is not the way it's supposed to be. And these are the red flags when you are considering crowns or veneers for anterior aesthetic cases. So this is an arch form after correction. So you can see this, the arch form has been corrected, and you can see that the upper premolar is completely rotated over here. Now, according to her history of orthodontic treatment, her upper 4s were extracted. So these are her 5s. She does not have upper 4s, but she has lower 4s and lower 5s. So there's a lot of issue with her functional occlusion in the posteriors also. There's a lot of problem with the arch form, as you can see. A lot of leaking posterior restorations, a lot of fracture of the posterior restorations. And there is a reason, again, why there is so much of fracture. I would like you to note the palatal convexity over here. You can see that it is not shallow. It is quite deep. I had to make it deep. The only way that you can convert shallow anterior guidance to a steep anterior guidance is by making the palatal convexity deep. So that is something you need to incorporate in the CAD design, in the crown itself. And do note that the incisal width of the central incisors as well as the lateral incisors are uniform. Okay, so we do not have a disparity in the width over here. It's not that the centrals have more width as compared to the laterals or vice versa. This is very important from the perspective of broad stress distribution in the anterior edge-to-edge position, that is in mutually protective occlusion. Because again, if there is a mismatch in the width, we won't have bilateral, simultaneous, even contacts between the upper and the lower teeth. So this is the lower arch form, okay? And you can see that she has both a 4 as well as a 5, and the 4 is completely out of the arch. So basically the 4 is actually interfering with the occlusion. It's probably traumatic. And the problem of the VD being less is clearly seen here. You can see these are PFM crowns. You can see that there is a chip in the ceramic coating on this crown, and that's because her vertical dimension is too less. And because it's too less, it cannot accommodate, there isn't enough space for both ceramic and metal. You can see that the morphology also isn't very deep. It's a very shallow cuspal morphology over here. Despite having such a shallow cuspal morphology, there is a fracture. And this is the reason why the restorations in the upper arch are also fractured, because she has very less VD. So in such cases, the restorations cannot be given very deep morphologies. They have to be very, very shallow. And it's a very strange orthodontic treatment history that she has over here. This is a position of mutually protective occlusion. Now you can appreciate what I wanted or what I was trying to explain all along. This was the end goal that I had in mind right from the beginning when I started out. By increasing her anterior guidance and converting it from shallow to steep, I have also increased the amount of disocclusion that you see in the posteriors over here. I have managed to achieve contacts between 1, 2, 3, 4, 5, 6, 7 of her teeth. Okay, this is not an entire contact. This is a half point contact. Because this is a very, very slight contact, and I couldn't do better than this. It wasn't possible to do better than this, mainly because her central incisors were tilted, and because they are tilted, there is contact achieved over here only on the distal and not on the mesial. And this would again have required a little invasive treatment. I would have had to, RC treat her tooth if I had to push this back into the arch. And it's okay. It was not needed. This is good enough. This is good enough. If you're talking about the perspective of the longevity of whatever we do, this is good enough. If you're talking about aesthetics, her lower anteriors are not really visible even when she smiles. So that's okay. It doesn't matter at this point. And therefore, we just left it. There was nothing done over here. Now,
Dr. Deepa, if I may interrupt you, there's a question for you actually.
Yeah.
By Dr. Tushar, and he's asking how to increase VD in such cases.
Yeah. Let me go back to the previous slide. So that's a very good question, Dr. Tushar, and I'm glad you brought that up. These cases are very tricky. You cannot actually increase the vertical dimension. See, what do I mean by VD? I mean by the VD has got two components. We all know that we have vertical dimension at rest and we have vertical dimension at occlusion. The vertical dimension at rest does not play as much a role in fixed prosthodontics as it does play in complete dentures. So I'm not going to go into too much detail there. So what we are talking about, when I talk about VD here, what I mean is the vertical dimension in occlusion. So when I talk about the vertical dimension in occlusion, hold on. Back to the other slide, which showed, and this is the slide. Yeah. So when I talk about vertical dimension in occlusion, we are talking about this, the VD here and the VD here. Now, these cases are very tricky because if you want to increase the VD here, you have no choice except to do complete orthodontic treatment with extrusion of these teeth. You will have to actually extrude these teeth in order to increase the VD, and that may not always be possible because this patient was a skeletal class 2. So sometimes it's not possible to increase the VD to such an extent. Or the other way to increase the vertical dimension posteriorly here is a full mouth rehab. That's the only other way to do it. And because in this case, you can, since she's a case of, a class 2, but she's not a very deep bite. If you notice, her bite isn't that deep. So you cannot selectively increase the VD only in the posteriors. If you're going to try that, if you're going to try to increase the VD only over here, you'll probably get very less overjet and overbite over here. And the minute you do that, you've again compromised the anterior guidance. For the anterior guidance to be steep, you need 2 mm overjet and overbite. That is the reason why all the prosthodontic textbooks keep stressing on 2 mm overjet and overbite as the ideal overjet and overbite. The reason is because that 2 mm gives us a steep anterior guidance. So if you were to increase the VD selectively only in the posteriors, this would again get converted from a steep to a shallow anterior guidance, and whatever you've achieved here is lost. So you would have to do a full mouth rehab, which is literally crowning every single tooth in her mouth. And that is very radical. That is very radical. That is really not needed for such a young patient. She's only 20, 21. That's not needed. What we've done till now over here with just 2 crowns, that is good enough. So I hope I have answered your question, Dr. Tushar.
Ma'am, there's another question by Dr. Sonia.
Yeah.
And she's asking that for such cases, do we need to take protrusive records and fabricate the prosthesis accordingly? Or can it be taken care of during the BISC trial?
Okay, a good question. An excellent question, actually. See, the thing is, it requires a lot of experience, okay? So yes, I didn't do either. I'll be very honest. I neither did a BISC trial and neither did a protrusive record. I just made my impressions. I sent it to the lab. I asked them to share their exocad with me. And I gave them the go-ahead. They milled their crowns. I just cemented the crowns and I sent the patient, and that's that. But in reality, it's not so easy. And not everybody can do it this way. Now, why I could do it this way was because from experience, I knew that I had to convert her anterior guidance from shallow to steep. And therefore, I actually told the lab to make sure that that anterior guidance was inputted in the exocad at the time of milling these crowns. So as I said, this, if you're going to do it this way, you really need to know what you're doing, and you need to have a lot of experience where you are able to visualize mentally by how many degrees you need to change the anterior guidance and how much is enough. And if you do not know that, then yes, you have to take a protrusive bite. Then you need to, set it on a semi-adjustable articulator, inputting that protrusive bite. Then you need to check on the semi-adjustable articulator how much of the anterior guidance has to be increased in order to get, broad stress distribution in NPO, or else you may have to check it in the BISC, but I would not recommend checking it in the BISC. The reason is because, see, these are not PFM crowns. These are zirconia crowns. Okay. So since they're completely CAD-CAM zirconia crowns, the only thing they're doing is the lithium disilicate layering. But the convexity of the palatal surface, that's already milled. That's already been milled in your CAD. So if you've gone wrong and you have not accommodated for a steep anterior guidance in your CAD, you have not provided for enough convexity on the palatal surfaces of your 2 crowns, you cannot now change it in your BISC. You'll have to redo the whole thing. So it's very tricky, very, very tricky. So I would not recommend doing it in BISC. If you're like me and you can visualize your end result and you're able to guide your technician into inputting the correct angle for the particular case, you can do it the way I did it. Or yes, please do take a protrusive bite, do a phase 4 transfer onto a semi-adjustable articulator. And this part, either the technician has to do it or we have to do it, because sometimes the technicians don't understand how much of anterior guidance to give on a semi-adjustable articulator. Sometimes it's better we do it for the lab, and we send it back to the lab and say, okay, this is the amount of anterior guidance that you need. Do not change this. Do not increase it. Do not decrease it. Keep it as is. So this is the one thing that you need to keep in mind. You cannot correct it in BISC. In this case, you cannot correct it in BISC. You can only correct form in BISC. You can change the shape to a little extent. You can probably add a little bit of texture, and you can change your nasal or your distal incisal angles. You can even change your width, or you can change your length a little bit. But the parietal convexity is something that's already milled. So if it's gone wrong, it's gone wrong. And in this case, we didn't give too much texture over here because she didn't have much in her laterals and in her canines. The reason she didn't have much is because post-orthodontic treatment, she had the residual, you can actually see the marks left behind by the bonding adhesive of the brackets. And by removing that bonding adhesive, a lot of her texture has been lost. So if I were to give her very deep texture, it's not going to look good in this case. So therefore, we just stuck to very subtle texture. Any other questions with respect to the anterior guidance?
No
Dr.
more
Urvashi?
questions, ma'am. No
Okay.
more questions, but I would just wanted to remind you that we are nearing the 1 hour
Yeah, I'm
mark
almost
for
done.
our webinar. So if you
Yeah.
could just, yeah.
Yeah, I'm almost done. I don't have much now because most of the important points have been corrected. So now if you see her canine guidance over here, here it's, look at this path, wear path over here. It's almost got converted into a group function over here because it's not just the canines which are in contact. The upper molar and this lower premolar are almost in contact, whereas here it's not in contact much. But the main point of focus over here is her laterals are also in contact. So it's not a pure canine guidance, it's a canine lateral guidance. So when she came to me initially, she had canine and lateral guidance on one side and she had only canine guidance on the other side. So what I did was I did a little bit of enameloplasty on this lateral incisor over here so that I could achieve the same on both sides. Again, why? Because I want broad stress distribution. I don't want only these canines to bear the brunt of the masticatory load in canine guided occlusion, whereas here the canine would share it with the lateral. I wanted it to be bilateral and even on both the sides. So a little bit of enameloplasty helped me achieve that. So this was the modification that I did, and these things are very important when you take up cases like this. Sorry, did I skip a slide? No, I didn't skip a slide. Okay, so now I just, shared this. It doesn't have anything to do with the topic of crowns and veneers, but the reason I shared it is because I mentioned this earlier. A lot of our restorations are fractured, if you notice, and as I said, it was because you cannot give very deep morphology in such cases since the VD is less. Being a typical Indian patient, she only wanted to get this tooth done, and I said, fine. So it was just sculpted freehand chair side, but keeping the functional occlusion in mind. The morphology was very shallow, and it hasn't fractured since then. Similarly, in the second quadrant, she wanted to get only these two done and not this done. And again, shallow morphology over here. So when either it's very difficult to customize the occlusion chair side. Again, it requires a little bit of experience, or else you may need to probably get a wax up done from the lab, and then you can make an index out of it, and you can injection mold, or you can just layer it and just use the putty index and do it. It's a little difficult to do it chair side in these type of cases. So you can see her smile and profile. It's a very natural smile. It's impossible to discern which are the crowns, which are her natural teeth. And even though the patient is a class 2, the correct arch form makes a lot of difference, because when you see her smile and profile, it's not very obvious that she's a class 2. It's not that obvious at all. So this is the patient, okay? And she very, very kindly agreed to share a picture of her smiling with all her anterior teeth visible with me for educational purposes. And this picture has been posted after permission from her. You can see a very happy young lady who's got a really radiant and a very beautiful smile, okay? And a few people may notice that her facial midline is not coinciding with her dental midline. There is a slight shift because, dental midline is here and her nasal midline is somewhere here. Her nasal midline is slightly to the right of her dental midline. And that's okay. That's fine. That's okay. Because if I have to get her facial midline to coincide with the dental midline, I definitely cannot do it in 2 crowns. I will have to shift her entire arch more towards the right, and that's probably going to end up crowning several teeth. We are talking about crowns here and not veneers, because this case is not a case for veneers. So we're going to have to crown so many teeth and prep so many teeth, and it's really not needed. It's not worth it. She's not in the beauty industry. She's not a model, so the She just wanted a natural smile, and that's what we've given her. So a smiling face is a beautiful face. A smiling heart is a happy heart, and that's really true. And if any of y'all wish to connect with me at any point with respect to this webinar or any of the future webinars, feel free to do so. I'm there on Facebook. I'm there on Insta. These are my handle names. This is my profile. You can connect with me there too. So with that, I end my presentation for today. Dr. Urvashi,
thank you so much.
Can I stop sharing my screen?
Thank you so much, Dr. Deepa. Yeah, we can see you.
So I'll stop
am I audible?
sharing.
Can you hear me?
Yeah, you are audible, and I'll just go back to the webinar. Yeah. So
thank you so much, Dr. Deepa ma'am, for the wonderful session and enlightening us on the different topics that are encompassing occlusion, anterior guidance, functional occlusion, smile rehabilitation, and how it's not so easy to do a minimally invasive, job, even with crowns. There are so many things that are going on. That was a lovely case that you demonstrated, showing us exactly what you wanted to tell us. So thank you so much. I would also like to take this opportunity to thank our sponsors, Group Pharmaceuticals and Shai NM. All the participants will receive their e-certificates within 3 business days. And also the participants, if you wish to watch this webinar again, or you want to refer to your friends that you have missed out on an amazing webinar and you need to watch this again, do let them know and do spread the webinar details so that everybody can watch it before the next session, because it's really important that we watch the entire clinical series in an order. So if you miss it, I would say that please go back and watch it so that you're able to, take the notes and be ready for the next session that we have coming up.
Yeah, because there are certain concepts which, if I've explained in greater detail in the previous webinar, I will not be explaining it in so much detail in the next webinar, because there would be other things that I would want to focus on. And see, ultimately, everything in Prosto is interconnected. Okay. Whether it's your anterior guidance or whether it's your group function or your canal guidance, your VD, everything is all interconnected. And true success or failure of our cases chairs side depends on our ability as a clinician to connect all those invisible dots in our treatment planning itself, so that we do not have issues neither with the patient, nor with the lab, nor with the prosthesis, and everything goes fine. So I had completed this case in 2019 and it is now 2022 and everything is, fine. Because the functional occlusion, it requires about 6 months to set in. So if there's any breakage, anything is going to go wrong, it's going to take place in the first 6 months. So if you cross the 6 months period, it's going to last for a really, really long time without any issue. So I really thank all of y'all for being there in the audience, and for the we never had the second poll question on anterior guidance. Did we have that? I think
actually we do have it. I thought you skipped it and then I didn't. But you
I forgot. Did you take the poll question?
No, I was waiting for
you. Can you do it now? No, please do it now before we end it.
Now?
Yeah, please do.
Okay. Please do you want to give a small explanation regarding the
No. I think now that the webinar is over, they would have a lot of clarity in their answers. So let's just go ahead with the poll.
Okay, guys. So the poll question is on your screen, and whatever you have learned in this webinar, if or recollecting all of that knowledge and the points, if you could just put in your so the results are coming in, ma'am. You can see them. Are you able to see them?
Yeah, I can see that 100%. So it's very clear that my aim of this webinar has been achieved. So
I think it was nice that we skipped it so that we could have it at the end.
Actually, because that's how sometimes things just work out for the better. So yeah. So yeah. So if anyone has any doubts, any questions, as I said, feel free to connect with me at any point. Okay. Yeah. So shall we sign out?
Yeah, I think we can close the session.
So Dr. Roxon, shall we end it?
Yes, ma'am.
See you guys next time. Bye-bye.
All right. Bye-bye.